Chronic pain can ruin your life, but so can some of the treatment options. Are there new approaches to reducing pain or even eliminating it? A different approach to pain tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Tonight we come to you from South Dakota's Public Broadcasting in Sioux Falls studio. It's a wonderful location. It's exciting for our team to be originating the program from a new location. And we have a studio audience joining us to ask questions or give us their thoughts about tonight's topic. So you guys have an obligation to give us your feedback. Thank you. Woohoo! We call people we don't like a pain in the neck, or tasks that we would rather not do are just a pain. We don't like pain, and we want to stop it sooner rather than later. But there's another story about pain as it keeps us from burning our hands as we pull it from the hot stove. First, let's take a look at this week's Prairie Doc quiz question. It's a multiple choice question tonight. A physical rehabilitation physician, physiatrist, A, works to cure joint pain. B, tries to maximize patients' independence in activities of daily living and improve quality of life. Or C, works in both the hospital and the outpatient setting. We'll have the answer later on in the program. Because of our location in Sioux Falls tonight, we can't take your phone calls directly. We will, however, answer your questions about pain treatment as they are sent to us via Facebook or email. Post your questions to the Prairie Doc Facebook page or to the email address ask@prairiedoc.org. Joining us tonight is a longtime friend of all of us here at On Call with the Prairie Doc, Dr. Judith Peterson of the Yankton, South Dakota Medical Clinic. Thank you for joining us, Judith.
Thank you so much for having me, Rick. It's such a pleasure to be here. It really is.
And you know, you're my co-author on the first book we came out with, The Picture of Health, A View from the Prairie.
I remember photos, not words.
I remember the words. It's funny. So your photo matches the essay, and it was like the first 5 years of the TV show, and we put the essay, and then comes this artistic photographer, Judith Peterson. I was trying to think today how we came together, and I don't remember. Do you?
I think it was my husband.
Maybe that was it. I know of a really good photographer, and I'm married to her, and she's an MD.
He was impartial.
Yes, an impartial, biased advisor. So we're talking about physiatry, and we're talking about help with chronic pain.
Right.
And we're going to talk about any issues of the musculoskeletal system or the emotional system, all kinds of different kinds of pain. And we're going to talk about how physiatrists approach these things. We may talk about how other doctors approach these things, but let's talk about physiatry or rehab medicine. I mean, what is it? I mean, a lot of people don't know what a physiatrist is.
Well, right. And, you know, I think that that's a really good place to start. Rehab medicine, physical medicine and rehab, is a subspecialty that's recognized by the American Board of Medical Specialties. And so physical medicine and rehab doctors work to help understand and manage a wide variety of issues that can affect function. So, for example, carpal tunnel syndrome, chronic ankle pain, low back pain, all of these things fall under physical medicine and rehabilitation. Stroke issues in both the acute setting, and then also if people are troubled later by pain or spasm, this also is within physical medicine and rehabilitation. So the way I think about physical medicine and rehabilitation are doctors who are trying to understand what's going on with a patient that might be limiting function or causing a painful issue, and then try to create an overall management plan for that and to help restore function and help with pain control, et cetera.
I love what you say when you say the word function.
Yes.
Because we all talk about different kinds of rehabilitative things, and particularly approaching pain. But sometimes you don't eliminate pain, but you can get them back to function.
Correct.
And they're
Correct.
dysfunctional because of the pain. How can we get them back to regular living?
No, absolutely. And a patient comes in with difficulty walking, for example. It could be that their foot is numb. It could be that their ankle is not mobile. It could be that they have so much low back pain with walking that they can't walk. But these are all issues that a rehab medicine doctor, a physical medicine and rehab doctor can help sit down and try to formulate a plan to get that patient back to walking, which is, what is our goal.
Right.
And it's what and it's a shared goal, I might add, with the patient.
Right. Mobility.
Right.
We've talked about falling as a big problem, and older people have trouble mobility and then falling.
Right.
And there's a whole thing about use of the cane, what it does, and so on. Let's talk about prevention of falling, because of the things that seem to really rub a geriatrician wrong is all of the reasons why people fall. One of the biggest reasons is pain medicines.
Right.
Or tranquilizers or
high blood pressure medicines.
High blood pressure medicines, medicines to help peripheral neuropathy.
Right.
Anxiety medicines.
Right.
Tons of medicines are the culprit, but other things are the culprit. Losing your balance from brain.
Nerves in your feet.
Yeah, nerves in your feet.
You don't see the floor well.
Vision.
Right. Your floor has too many impediments on it, too many throw rugs, too many stairs.
Too many bumps.
Too much whatever. So, there are many, many issues that can contribute to fall risk in the elderly.
So what do you, as a physiatrist, rehab doctor, do to help people with balance issues and falling and addressing these particular issues?
Well, I think the first thing is, we tell people when we want to help them avoid falling is we say, let's get rid of fall risk in your house. So all those barriers, the throw rugs, think cords that people can trip on, one iPhone, 12 cords, right? For most houses.
I mean, why does that
that's
ring
the ratio. That's the
Yeah.
ratio. So myself included, of varying lengths. So first thing is clear the surfaces so that people have easy access within the house. Why make it more difficult? So that's the first thing. The second thing is, when we think about fall risk, is there weakness? So many people from chronic hip issues or low back issues, they actually have weakness. And with improved strengthening, they can decrease their fall risk.
So you give them exercises that they
Correct.
are to do.
Exactly. And then in addition, people can be given specific balance exercises. And then for those people who are trying to just kind of do this on their own, who want to decrease fall risk and don't want to necessarily see somebody yet,
Who might be watching right now.
who might be watching right now. I mean, one thing to think about is if you want to get involved in some type of program to help, is to get involved in something like Tai Chi, which can be adapted for multiple levels of difficulty with your balance and can be very helpful in terms of fall risk reduction. But there are other programs too, and we can get physical therapy involved if necessary, et cetera.
Yeah, I have often consulted one of the programs at our hospital, I'm blocking on the name of it, to do a home safety check.
Right, either occupational physical
OT.
or physical therapy could do that. But people are older, they can have part of their visual field can be affected. They can truly have trouble seeing the floor. People can have stiffness. Parkinson's issues can affect fall risk. So these are complex issues. And the plan will always want to really deal with that specific universe of the patient. every patient kind of lives within their own field of challenges, and we'd like to tailor it as close as possible to that patient's needs so that patient can have the absolute best outcome.
Okay. I am looking for questions, and I'd love to have email questions. I'd like to have questions from the audience. And oh, by the way, I've got a couple questions from the audience.
You do?
Do you have suggestions for coping with pseudogout? And is inflammation due to diet, lifestyle? What would you suggest?
Well, pseudogout is
Different than gout. We can talk about both.
right. I mean, we talk about inflammation. I mean, pseudogout is a condition that becomes more and more common as people age. And boy, talking about pain, can this be painful? And pseudogout can present in a lot of different ways. I think one of the first things is to make sure the pseudogout is actually the problem, because people can be told, oh, you have pseudogout, but it may just be something that popped up on the x-ray that isn't necessarily the cause of the problem. But let's say, for the sake of argument, somebody is having a pseudogout flare of a joint. There's a lot of different options in terms of helping it, ranging from things like, if it's a hot joint, cooling it down, ice, to medications.
There are medications that we could and should talk about.
Absolutely. To injections for, to kind of decrease all that red hot inflammation. So depending upon what's affected and kind of what is in the immediate environment of the inflammation crystals, we might handle it differently. But in general, we're trying to bring down, if it is truly the pseudogout that's causing the problem, bring down that red hot.
Inflammation.
Bring down the red hot.
And pseudogout, one quick question, we got to go to the roll in. Can pseudogout and gout or gout occur in the back?
Pseudogout,
In the joints of the back, all those, articular things in the back.
More commonly we see it in something flaring like a wrist or something like
That's
that.
out cool, in a cooler area
Yeah.
of the body. So
Yeah.
not common.
Not to my knowledge.
Okay. When one has back pain, whether chronic or short-term, it affects the whole of daily life. This creates a willingness to do almost anything for relief.
A lot of people that have back pain, they've been having this pain for many years. And some people are maybe a weekend warrior and they've gone out and they've pulled something or did something to their back and they have an acute disc herniation or a sudden onset of pain. So that's another very common subset of people that I see. People with acute back pain tend to be in much more severe pain. It's a pain they're not used to having, and it's something that really alters their life quite significantly right away. People with chronic pain tend to have pain that they've endured for a long time, and they've already developed many coping mechanisms, and they're just really looking for a way to help alleviate some of those things with the chronic pain. Can some of the coping mechanisms be harmful? Yeah, sometimes people get such awkward body changes in the way they walk or the way they position or the certain way they carry themselves that's just not normal for them to have anymore. And after you do a surgery and you alleviate a lot of those symptoms, they may still have some of the bad habits, and that's why it's very helpful to have them work with our therapists to help retrain their bodies to be in a more of a better situation and awareness of how to carry themselves and to be different after a surgery. So what I look for when I'm looking at a CT or an MRI or deciding when is it time to take this person to surgery or when should we continue with conservative treatment, the things that I look at are really the duration of symptoms and the type of symptoms. If people have symptoms for 6 weeks or so or even longer, those are symptoms that tend to be less likely to go away on their own. Or if they've done injections or they've done other non-operative treatments or many of the other modalities like therapy or chiropractic, and they have been unable to achieve a satisfiable result in the decrease in their pain or increase in their function, those are the people you start talking to more about possibly being able to help them with surgical management. So what's changed in spine surgery over the years is instrumentation has been much more refined, really just since the 80s when we started doing rod fixation and things like that. Now we've developed pedicle screws and minimally invasive techniques where incisions have gotten much smaller, and the way that we are able to treat perioperative pain and control things have just gotten a lot better, and a lot of the techniques have been further refined to help people achieve better outcomes.
This is your program. Your questions are key to the direction of our discussion. Post your questions to Prairie Doc Facebook page, or send us an email, or give us a paper question, and we've got more out in the audience, and we sure do thank you. So this was an interesting approach to low back pain, but there's a time to do surgery. How do you differentiate? You know, you're in the middle. You get the complex low back pain cases, and then when do you send them to the surgeon?
You know, I think that for surgery, it becomes a question of, first of all, if somebody has true weakness, loss of bowel or bladder function, this is something that probably really does need to be looked at from a surgical perspective. When we talk about, you know, back pain can be from many different causes. It can be from the most common thing that you and I see and over and over again is degenerative disc disease, which is a doctor's fancy way of saying there's a lot of arthritis that's affecting a lot of different joints in the back that can potentially be pressing on nerves, giving pain with walking, etc. So, but if people...
But when you see loss of function...
Right. If you see true weakness...
Where they can't bring the foot up.
Can't bring the foot up.
Bowel or bladder
Bowel
problems.
or bladder, you know, these, in my opinion, really have to be seen by a spine surgeon.
And then
we don't want people to get worse.
Right.
So there's that. But
I wanted to add, then that surgeon may or may not order a CT scan or an MRI. I wanted to say MRI is magnetic waves.
right.
So, but go on.
Right. And then I think that it becomes a question of what is reasonable care. And so if a patient has been given 2 ibuprofen and told, oh, this is a therapeutic failure, you're still having a lot of pain.
Time for surgery.
This is probably not a good treatment plan. This is probably something that could really be improved upon. On the other hand, if the patient has had, you know, extensive physical therapy, has given a variety of medications a trial, for example, we know that the narcotic medications
Are not really good for musculoskeletal.
they're not good for nerve pain for sure. And so, you know, if somebody's having a lot of tingling and numbness down their leg, and we're just depending upon Tylenol number 3 to be the answer, this is probably not going to work out the way the patient wants it to work out. I like to think about the medicines and injections as the beginning of a road into the difficult path of rehab and getting things stretched and strengthened again. And I think the vast majority of the time that will work out. Some people may benefit from nerve blocks that are available. There's a term that's called multimodal approach. And that's, again, a fancy way of saying, let's try really hard and let's try a lot of things and let's be open to ideas about how to help patients. And one of the things that we hardly ever discuss, but probably should talk about more, is if somebody is having back pain, okay, if you have shoe wear that does not have any shock absorption, this is probably not ideal. If you're in a car that, you know, hasn't had the springs looked at in the last 2 presidencies, this is probably not ideal. You know, it's because, you know, if we're having trouble with our internal, world, maybe we need to look at what are the stressors outside, which brings me to if somebody is having a lot of pain and there's a lot of body tension and a lot of issues with that.
Emotional pain.
Right. We know that cognitive behavioral therapy can be very helpful for people with a wide variety of pain issues, along with other techniques such as meditation, et cetera.
I think about, I was preparing to write an essay about chronic pain. And I put it in front of about 10 guys. We were having a sailboat meeting and talking about the importance of sailing and, and over a glass of beer and a steak grilling on the thing on a Wednesday evening. And I said, what's the most painful experience you've had in all your life? And I'm thinking, you break a bone, it's in the worst pain that you're going to have for a period of time, and then, in 6 weeks, it's gone. And I went around the room, and not one of them said a physical pain. That every one of them had a loss of a father, or a divorce, or an emotional base to it. And I thought right then and there, I deal with a ton of people in my practice with a great deal of pain, and sometimes I misinterpret when they say, my back is really hurting. What they're really saying is, I am crushed by the loss of, or the tension that farming is doing to me, or that there might not be enough rain this summer, or there's too much rain and there's flooding. Those stories, people come in, guys don't come in and saying I'm depressed or I'm saddened or I'm having emotional pain. They'll say, this hurts. And we have to hear, not always, but we also have to feel that or sense that emotional part. And then, of course, that doesn't go away in 6 weeks like a broken bone.
Right. Well, and I think you bring up a critical point, which is the patient says, doctor, my toe hurts. So the patient has toe pain, and the doctor says, you have toe pain.
Yeah.
But this is not a diagnosis. The diagnosis is you have arthritis of the toe, you have a fracture of the toe.
You have gout.
Your shoes are too tight. You have gout, but just something so that you can hopefully do a more specific treatment plan. But you bring up also a very important point, which is that, many, many patients who have chronic pain have understandably, issues surrounding the management of that from a psychologic perspective that are helpful to the patient to be addressed.
And you start with a gouty pain, and then there's this emotional part that comes along.
Right.
So it may well be that it's two things.
Right. I can't
We have
walk,
a
I can't dance, et cetera.
I can't dance.
I can't, exactly.
I wanted to ask, point that you are the official doctor of the Pennsylvania Ballet, are you not?
I am indeed.
And you've written a book about ballet.
But they haven't put me on stage.
They haven't put you on stage.
Not yet.
Is that a good thing?
They've threatened, actually.
What about the book you've written for ballet pain or ballet issues?
Yeah, well, I wrote a book because I thought that it would be really important for the dance world to have something that was for dancers. I thought there was a lot of doctors talking to other doctors about things, but very little for dancers. And actually, when you look at the studies, at any given time, about 70% of the dancers on a stage will have a pain issue or an injury. 70%, the majority. But there wasn't really a reference for the dancer. So I wanted a simple, clear book for that population.
And you got it done.
And I got it done.
And published.
And published.
That's wonderful. We have questions. Here's a question. What is the most effective method of pain management? So I know you just said multimodal, and that's kind of what you want to do, lots of different kinds. But what would you say is the most effective?
I don't know that I can answer what is the most effective, but I think I can answer what I think is a critically important path to progress, which is I think that the patient needs to have some understanding of what is happening. I sit in the office and I ask patients, I say, do you understand what I'm talking about? Because I think many times it is very disorienting to be in a physician's office. It's very disorienting to be in a hospital. And I try to make sure that the patient understands what is happening, so that way we can formulate a treatment plan together, because I think that ultimately
Is the best
will be the most effective.
Yeah. Here's a question. Causes an effective treatment for plantar fasciitis. So what is plantar fasciitis?
Well, the plantar fascia.
And I'm one who's had it, by the way.
Yeah, it's so common. I mean, plantar fascia, plantar is foot. And so fascia is a doctor's fancy way of saying that strap of tissue on the bottom of your foot starts to break down, gets tiny little tears in it, gets stretched, and wow, is there a lot of pain.
Now, and I've often thought of it as like the bowstring on a bow.
Yes.
The bow being your arch.
Yes.
And the string keeping the bow strung.
Right, except, the thing is, I will tell you that the risk factors for are a foot that's too flat or a foot with too high an arch, which means that
That doesn't fit the bowstring
which means
thing.
that a lot of people are at risk, apparently,
Yes.
from a lot of different kinds
Everybody.
of arches. Basically, when we look at plantar fasciitis, we know that to some degree it's a degenerative condition for a lot of people. Exercises to strengthen the small muscles of your feet actually are really helpful for this condition, and stretches for the bottom of the foot and the Achilles tendon are very helpful for this condition.
But the reason I got it was running too much.
Running, yeah, common in runners. And, other things like heel lifts can be helpful as well. But, it's usually a combination of stretching, which we've talked about.
Ibuprofen.
Strengthening, which we've talked about. And, anti-inflammatories, I don't know so much that they would heal it. But, certainly strengthening the small muscles will get one a long way.
Okay. And a little time.
Right. And, there are other things such as injections, et cetera. But, hopefully one can heal this with conservative treatments.
Comment on the connection and relationship between chronic pain and depression, how to get appropriate treatment. So that's a great question.
It's a great question.
Chronic pain, depression.
Well, I think that whoever asked that question brings up a very important question, because we know that there's a very high rate of depression among people with chronic pain. And so I think that we don't treat depression typically with nonsteroidal anti-inflammatory drugs.
No, we don't, do we?
We just don't commonly do that. And so that tells us that we need to have a little bit more precise treatment plan for that. And, I think that's working with, the social worker, the psychologist, the psychiatrist, the primary care doctor, the spiritual advisor, the families, to get a comprehensive approach to this, and medications if necessary, but certainly not to say, we're going to give you your ibuprofen and we just know this is going to solve this entire thing, because it won't.
And we don't know which is the chicken and which is the egg. I mean, could be chronic pain causes depression. My sense is there's a lot of chronic pain as a result of depression. An antidepressant is very effective, but it's not nearly as effective as exercise and an antidepressant. That was kind of hard to say.
Well, you bring up a critical thing, which is exercise has a positive effect on mood for many patients. And this is there's a fear of movement that can happen with pain, but to the extent that you can keep moving, because it has a very positive health effect overall.
Bingo. See, I was not the only one to say that. I was not the only one. We know that motion is the lotion with some chronic pain, and that movement and exercise can be key to helping alleviate symptoms. We take for granted now the exercise opportunities we have throughout our lives, the wellness centers, the school athletics, and collegiate sports. For us to have these options today, there were people who built the foundation upon which modern exercise programs now operate. Cleveland Abbott was one of those pioneers.
His parents were either slaves or children of slaves in Alabama. They came up in the Great Migration of the 1890s to South Dakota looking for that chance for a better life. And in their process of coming to South Dakota, they ended up going from Yankton to Brookings to Watertown, where they were able to raise their children. Cleve's mom died when he was just a child. And he had to grow up and go through high school and college without a mother. All of the skills that he could develop here in South Dakota, that South Dakota gave him that chance to perform in multiple different ways. He was the cub reporter for the Watertown paper. He was a bellhop at a Brookings hotel. All through his childhood, he was developing ways to get along with people to make change. He was lucky enough to have a very perceptive college president that was involved with his life at South Dakota State, who happened to bump into Booker T. Washington on a train. And Booker T. Washington hired this man sight unseen as about a 20-year-old to come down and build an athletic program. In 1916, he went to Tuskegee and became the football coach for Tuskegee. 1917, World War I broke out. He was chosen to be a leader of men, one of the very first African Americans who could be serving as an officer in the military. One of the things that they did, because a young girl had approached Cleve at an event and asked if the girls could run, because the boys were having so much fun that they wanted to be part of the Tuskegee relays. They were able to take the Tuskegee relays. They built what's called Alumni Stadium at Tuskegee so that they could hold the carnival, the relays, in a structured environment. Girls were involved, boys were involved, everybody was involved. They even brought in high school kids to be involved. And what they did from that point on, and we're talking in the late 1920s, was build an athletic program that became the foundation for our modern women's athletic programs and the modern NCAA programs of intercollegiate sports. There had to be a great deal of pain in his life. A mother dying when you're 12 or 13 years old is horrendous. And he had to go through life with this. The indignities that would happen when he was in the service, because he was, of course, in the segregated military. He had to help his soldiers overcome that kind of pain that they were all going through. They were trying to be accepted, and they were accepted in France, and as soon as they came back and were mustered out in Georgia, they had to go back to Jim Crow again, and they had to suffer more.
That was a great story, and we appreciate it. And we just happen to have Bruce in the audience. And we thank you, Bruce, for that story and for that information and for putting Cleve as a member of the South Dakota Hall of Fame. So we got a bunch of questions, Judith. We should probably dive into these.
Let's do it.
What is pseudogout? We talked about pseudogout, but we didn't explain what pseudogout was.
You know, it's a kind of crystal that gets deposited. And, you know, if you think about something hard and solid within your joint,
You can understand the pain.
Think how good that might feel.
And it's that inflammatory
Right.
response. What alternative treatments or non-medicinal therapies exist for complex regional pain syndrome? What is that?
You know, complex regional pain syndrome is when one part of your body gets this really profound, diffuse pain response, and it's a complicated issue to discuss. But there actually are a lot of different types of treatments, which include injections. Medications are part of the treatment, but actually we know that moving the affected part really, really helps, because people with complex regional pain syndrome
move it.
get stiff. And so we need to keep moving on that too.
It used to be that people who had angina, now we treat it and get the
Right.
thing fixed, their whole arm would become
Correct.
Paralyzed because
Right.
they had arm pain whenever they exercised, and they stopped moving their arm.
Right.
Same story.
Well, right, similar. You get additional joints involved beyond the initial area. You have to keep moving.
Movement, motion is the lotion. Do you recommend acupuncture?
I think acupuncture can be beneficial for a variety of conditions. There are many different types of acupuncture. Acupuncture involves taking small needles and putting them into, according to
Meridian areas and so on and so
right,
forth.
into points along meridians. And it's been studied. It's quite good for certain types of issues. Basically, you want to make sure that somebody is using sterile needles, good technique, but it can be beneficial.
Okay. What role, if any, might medical marijuana play in pain control? What if your physician prescribes a more potent pain medicine than you think you will need? Should you fill the script or ask him or her for something else? So that's it. First, the medical marijuana.
It's really not part of my practice. I don't really think I can speak to that.
Okay.
I can speak, however, if the doctor is giving you a medicine that you're uncertain of.
Don't take it.
Well, that's a nice succinct way of saying, why don't you get more information
Yeah.
about that? Because, the doctor may have a perfectly valid reason why this is the safest, best thing for you. But if you're unclear, well, I think, a follow-up question is good.
Okay.
To that.
And I would answer in my own research on cannabis is that there's a lot of data now, and it's rolling in as it's becoming, we can do research on it. For the longest time we couldn't. That is very effective for certain people, for certain types of pain, and loss of, and nausea, and loss of appetite. So there's a variety of, there's future there, but we got to be careful, and there's a lot of research to be done.
Right.
What role does physical touch play in, for example, by another person, in mediating pain? And my hospice nurses do physical touch.
Well, I think that we are humans, and we are part of a community of people on Earth. And, I think that, massage has been studied for years and is helpful. There are varieties within massage, petrissage, et cetera, that are helpful for different kinds of conditions. And I think that human contact can be helpful to people. I think we have to be respectful of boundaries. I think we have to have a pretty good read on what people are looking for. But if we're talking specifically about treating musculoskeletal conditions, massage can be helpful for many, many things. And if we have women, for example, who have lymphedema after a breast cancer surgery, we know we're going to be doing specific touch-related techniques to help clear that, along with sleeves, et cetera, to help decrease swelling.
I'm a hugger, and I've learned long ago that you don't hug everybody.
Right.
I remember patting a lady on the back as I was walking past her in the hospital, and I've observed her and seen that she's always kind of angry, and I went out and I patted her on the back, and she said, "Don't you touch me."
Well,
and so there's certain people that you don't want to touch. I mean, because it'll hurt them. They're not used to it, or there's something going on in their lives that they weren't a toucher.
well, right. And I think
It's a threat to them.
we have to be respectful of, where people are. And culturally, there are differences.
Yes.
And I think we have to be respectful of that, because people come from different backgrounds, people come from
Yes.
different cultures, people are in a different headspace, and we can't see that.
I've heard that between the elbow and the shoulder is a relatively safe touching place. Have you heard that before?
Not with my cat, but perhaps with yours.
Okay. All right. We have from email, I have a friend who has shoulder pain. His doctor gave him a cortisone shot, which seemed to help a little. Now the pain is back. How often can he have another injection? And should he have an x-ray to see if there's a rotator cuff issue or something else?
Well, that's a great question.
Ooh, that is.
That's a great question, because basically what you're saying is a therapy helped for a brief period, but there wasn't long-lasting relief, is how I summarize that. And so I think the first thing is to go back to the original diagnosis. What were we treating? And so probably getting more physical exam findings, a better history, and possible radiography. And then saying, oh, okay, maybe it needs to be put in a different place, the injection. Maybe the injection needed to be followed up with a strengthening program. So it has to be thought about more holistically.
And then there's the orthopedic surgeon on my show a while back who said, and sometimes you just need to get those people to surgery. So we need to do an exam so we know. And so, of course,
Specific treatment.
Specific treatment. Email question, my sister who is 70 has poor depth perception. Could this lead to falls?
Yes.
Absolutely.
I think it could.
Oh, absolutely.
Sure.
And so I think that person in particular needs to be very careful.
Right. And possibly have somebody who's trained visit their house to make suggestions so that the kitchen is safe. Because kitchens, we have hot surfaces, we have sharp objects. We have
You reach in and-
oven doors that are opening.
Hit the knife.
We have, microwave doors that are opening. This is a frightening zone.
Right.
So,
I think OT consult, like we talked about earlier.
right, assessment.
Please discuss allodynia.
Allodynia is when impulses that are not ordinarily painful are painful. So for example, if somebody is stroking your forearm, that's ordinarily not painful. However, if you have a complex regional pain syndrome, for example, where the nervous system is really zipped up, that is allodynia if that is painful. And there are multiple ways to treat that, depending. One way is simply to drown out a signal by providing direct pressure for some patients. When you provide a lot of direct pressure, there's so much neural input that everything shuts down and the pain kind of
It's sort of
settles
like
down a
pepper
little
cream.
bit.
That's why pepper cream works. This person said, I'm on I can't take gabapentin. Topical creams don't help. PT said, rub the area to desensitize, but this hurts. So she's getting that treatment.
Right. May need pressure, might help it.
Try and let her be the one putting the pressure on.
Yeah, and to make sure that pressure isn't put on in a way that it can cause nerve problems. May want to discuss that with the person who's helping her clinically.
Right. I have 2 herniated discs in my neck with bony protrusions and arthritis. I have not had an injection because of the bad stuff I have heard about cortisone. I have been told to do something before they rupture. What do you think?
I think if there's, usually the way people find out that there are discs out of place in their neck is they're having a lot of neck pain or a lot of arm pain. So one simple thing, if people are having a lot of trouble, is to do what are called neck isometric exercises, which are exercises, right, without moving your head, and that strengthens the neck muscles, which takes a lot of the stress off the discs. So that's one treatment that could be done. You could also think about discussions with the doctor if something like cervical traction might help in this specific case.
Okay.
You could also discuss if something like an electrical TENS unit might be helpful in this
Okay.
specific case.
And those things can be done until that person starts losing function in their arms or function loss.
Right. I mean, I think that, certain discs, the way they're herniated, pose more hazard than other discs. For example, if there's
Necks are safer?
Necks are a little less safe because if there's a lot of pressure on a disc that's pressing right up against the spinal cord, we always worry about losing motor strength in your arms or legs.
Okay,
If somebody had a fall, for example,
Right.
or if they were in a motor vehicle accident, for example,
Okay.
things that we don't ordinarily have full control over.
So we got
it's
three-
a little
oh,
scarier sometimes.
Right, so make sure you're monitoring carefully by a physician who knows what they're doing about this.
Correct.
We've got 2 minutes and 3 questions. I have a bone spur in my heel, which really hurts. Mobic is the medication I was given. I have done therapy twice without help. Is surgery the only answer? And a bone spur in my heel, generally taking away the bone spur does not help, correct?
The spur actually shows there's usually a lot of tension on the plantar fascia, And so if it's a typical thing, and actually stretching, rolling that out, injections can be helpful for that. There are
And
other
not surgery
treatments.
on a bone spur.
Not necessarily, no.
Is there data about activity and engagement to decrease awareness of pain?
Yeah, I mean, I think there's a lot of different types of psychological techniques that are out there to reframe pain and
Get them moving, get them doing, get them
Right.
active, get them,
Right.
instead of sitting there thinking about my pain. I've got pain, I'm really worried about my pain, I'm sitting here thinking about my pain.
Right. So, such as the cognitive behavioral therapies and things like that.
So where would you find out about cognitive behavioral therapy?
You could call, typically a psychologist's office would know about that, I
Okay,
would think.
all right. Are you familiar with the DVDs by Miranda Esmond White as a ballet dancer who has developed exercises to deal with pain even for the elderly? And do you have comments on her form of exercises?
No, but I'll have to go look them up.
Okay, and I'm going to leave you with that so that you
Take
can
that one.
take that one. And here's another question: is there any connection to the severity of pain and retirement? So, I mean, retirement. People retire and then the pain gets worse. Sometimes they're getting older.
Oh, the pain gets worse after retirement.
Yeah, and now the pain is worse. Of course, they are getting older.
Well, I think work fulfills a lot of functions for us, including social functions for us. And so I think that if pain is worse, it certainly needs to be clinically reassessed to make sure there's not a worse or different physical condition. But if it's a lack of social interaction that's leading to mood disorder, there's volunteer opportunities, et cetera, that could be done, and maybe that would be helpful, or speaking to spiritual advisors, et cetera.
I like the idea of activity. Well, now for the answer of tonight's Prairie Doc quiz question. It's a multiple choice question. A physical rehabilitation physician, A, works to cure pain, joint pain. B, tries to maximize patients' independence in activities of daily living and improve quality of life. That one's for sure right. C, works in both the hospital and the outpatient setting. That's right too. So the answer is both B and C. And the answer, the winner is Gert Folkerts, and it was Gert from Inwood, Iowa, who answered the question correctly. We thank you, Gert. A book will be in the mail to you soon. We'll be right back after this.
Extra, extra, read the Prairie Doc Perspectives weekly essay in your local newspaper. Over 55 newspapers across the state of South Dakota include essays written by Dr. Rick Holm covering a variety of medical and health-related topics. Ask your local paper if they print Prairie Doc Perspectives.
What is inflammation? Inflammation comes from the Latin words into the flame, like how moths are drawn to sustaining warmth of a springtime campfire and harmful self-destruction if they get too close. Inflammation is a natural phenomenon that can encourage sustaining healing, but also harmful destruction like a moth into the flame. During my first years of medical school, I was honored to spend my summers with multiple doctors practicing in Watertown, South Dakota. There, pediatrician Eberhard Heinrichs, MD, taught me about inflammation while we were examining a young child with acute juvenile arthritis. He pointed out how her hand showed 4 characteristics of inflammation famously described by Celsus, a Roman who lived at the time of Jesus. Dr. Heinrichs explained, these are the cardinal signs of inflammation: rubor, or redness, tumor, or swelling, calor, or heat, and dolor, or pain. That summer, a red, swollen, hot, and painful joint found with juvenile arthritis was not the only medical condition I saw resulting of inflammation run amok. Other destructive examples included asthma, poison ivy, psoriasis, lupus, and rheumatoid arthritis. Those years ago, I learned that we had anti-inflammatory medications to help patients with such unfortunate conditions, although side effects were considerable. In contrast, I also saw examples of how inflammation can be beneficial in fighting off invading infections such as skin abscesses, appendicitis, tonsillitis, meningitis, and sinusitis. Beyond this older and established knowledge, researchers have recently learned that beneficial muscle growth comes as a response to localized mild inflammation that follows exercise. Other studies show that low-intensity training like walking can reduce harmful chronic inflammation. All in all, not only can our bodies be harmed when self-destructive inflammation turns against our own cells, but our bodies can be protected and even sculpted by the yin and yang of balanced and healthy inflammation. Recently, researchers have learned of another yin and yang. We know that our bodies can recognize and remove, by inflammation, tiny cancers that pop up periodically. On the other hand, certain cancers can grow because of inflammation. This latter finding has allowed for even more new therapies. There have been great improvements in medicines relating to inflammation. Compared to what we had during those early Watertown days, we can now more effectively and with less side effects turn off harmful targets of inflammation, cool crippling arthritis, soothe devastating rashes, and even when used correctly, shrink certain cancers. Rubor, tumor, calor, dolor, like a moth attracted to a sustaining or harmful springtime campfire. A heartfelt thank you to our friend and guest Judith for volunteering to come to the South Dakota Public Broadcasting Studio in downtown Sioux Falls. It's always a wonderful hour when she joins our conversations. And thanks also to those who joined our studio audience. It's good to have your questions and input. It's been a while since we've had a live audience in the studio, and we sincerely thank you very much. And a big thank you to South Dakota Public Broadcasting for allowing us to use their studio, and the SDPB crew for their help with the production of our program, and our own crew who helped tonight too. Well, that does it for this episode from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
We often wait and wait to avoid going to the doctor, but it is important too. Men's health, prostates, testicles, bladders, and all that stuff. Next time, On Call with the Prairie Doc.
For more than a decade, Dr. Holm, in his role as the Prairie Doc, has emerged as a leader of healthcare education and communication in South Dakota and across the country. Every week, Dr. Holm and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free, easy access to the entire Prairie Doc library. Hi, I'm Jennifer May of Rapid City. As a board member of the Healing Words Foundation, I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishbeck Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
the American Academy of Family Practice Foundation and the South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Brookings, Madison, and Flandreau Medical Society,
Aberdeen District Medical Society,
Sioux Falls District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
Swiftel Communications.